Okay, we are live.
Yeah, good evening, everyone. So this is the first class in immunology. I think we have already discussed its relevance in fertility in our fertility masterclasses. But from there on to now, it has evolved a little bit, I think, and we are seeing more and more drugs which are used and abused. And as we know, immunology is one of the emerging subspecialties in fertility. We have immunologists, we have reproductive immunologists, and we have gynecologists who are doing immunology, and we have people who have set up their new reproductive immunology labs. So this will give us an introduction as to what is exactly that we are talking about in immunology and how to go ahead with this aspect of fertility related issues. Yeah, over to you.
So actually, this is the first session on this series, and this is basically going to cover and look into all the basic aspects of immunology. Okay, and it is going to be very boring because the basic aspect of immunology is something which is very tough to understand. Okay, because it has so many confusing terminologies. It has got something called as natural killer cells, helper cells, Th1 by Th2 ratio, CD4, CD8. And for people who are not very used to looking at all these types of things, one more I wanted to add: HLA, HLA-A, HLA-B, HLA-C. And when you are not used to looking at this type of things in your life, you are not going to be entertained enough, when you look at this. So I thought I'll actually try and make it short, and then I'll also try and make it somewhat interesting. Because if in case you understand this class, okay, then the rest of all the sessions which we'll be having is going to be like a cakewalk. Okay. But I think I can start the screen sharing, and then Shilpa madam can stop me if it gets too boring, because normally, as I told you, this is a boring subject. Okay. And let's see basically, okay, as to how we can crystallize the entire information and make the information sort of worth it for all of us, right? So see, this is what we are trying to look at. Okay, Shilpa madam, you can see the screen, right?
Yes, yes.
Okay, so reproductive immunology, basically, just try and understand basically what is our body's immunology. Our body's immunology is basically the defense ministry. Okay, what does it try to defend us against? It tries to defend us against any form of foreign pathogens. Understanding? That means it's a classical example of what happens to Dr. Shilpa GB when I come to Bangalore. Okay. I am a foreign body in her territory. Okay. So she will be desperate the minute I land at Bangalore airport. Okay. To make sure how fast I get out of Bangalore. Understanding? No food, no water, no drinks, nothing. Just come, get operated and go. Something like that. The same mechanism is followed by the human body, right? Identifying self cells as selves and all the non-self cells. That means all the foreign cells are identified as foreign, right? For this, for the body to identify this correctly, okay, there is something called as immune matching. And this immune matching is basically done by 2-3 people. This forms the basis for actually transplant medicine. Okay, when we try to select, for example, if I have to donate my kidney to Shilpa madam, though I have only one kidney, okay, then what will happen is she will not be able to accept my kidney because our HLAs will not be matching to each other. Why does our HLA not match each other? Because HLAs are something which are inherited from our parents. So basically, I get one part of the HLA from my dad and one part from my mom. Okay, now that is the reason why we choose things like daughter donating liver to the father, sibling donating kidney to the other sibling, something like that, because that HLA match will not occur, correct? But the problem of HLA matching comes when you have something. This is the clinical significance now. Okay, the problem of HLA matching, we have to understand very importantly in something called as consanguineous marriage, correct? Consanguineous marriage means siblings have got married to each other, first degree relatives have got married to each other. So in that situation, what happens is there is too much similarity between HLA-C, too much similarity in HLA-B, too much similarity in HLA-A. And that can be one of the important causes for consanguineous people ending up with abortions. Okay, so keep that in mind. This is your first learning point. Understanding? What happens in pregnancy? This is our pregnancy. So pregnancy mein 50% contribution occurs from the sperm and 50% contribution occurs from the ovum. Now, because of this combination of 50%, 50%, these people, let's assume they are in a love marriage, they have never met each other. So there is no HLA sharing which has occurred in them. Correct? So basically the embryo which is developed from 50-50 is something called as a semi-allogenic. Why semi-allogenic? That is because it is only 50% different. 50% is still derived from the mother. Understanding? Now, despite that, the pregnancy does not routinely abort. Despite that, the pregnancy does not routinely abort. In fact, the mother's immunology is such that it allows this semi-allogenic graft to not just grow, it allows this graft to actually prosper inside her body. Correct? And that is why pregnancy is a state where there is basically something called as immune modulation. Okay. Routinely, what would have happened? Routinely, any semi-allogenic material, it would have undergone something called as rejection. Understanding? But in pregnancy, there is acceptance, and that is why it is immune modulation. All right. Now, this is the very, very basic of what we need to understand. For the body to allow immune modulation and for the body to allow this particular person to prosper, okay, it has to make sure that the HLA effect which is coming, correct, 50% is going to come from outside. No, we just studied that. So that HLA effect which is coming does not come. Correct. So what does the body do? See, try and understand. Let me just mark it clearly. Yeah. So try and understand. The body, this fetus is a very smart human being. This fetus, normally if it goes and expresses HLA, HLA-A and HLA-B on its surface, okay, from the blood, there will be somebody called NK cells. Okay, this human being will come. Madam, are you able to see what I'm typing? Shilpa,
Yes,
madam?
yes.
Okay, fine. So this human being is going to come, NK cells. What is the full form of NK cells? It is basically natural killer cells. So that means, simple word, no, naturally they are built to kill. Understanding? It will recognize that HLA is somebody else's. It is not matching to the mother. This is not a perfect match. 50% is different, and it will immediately go and kill this fetus. Understanding? So God has devised the mechanism for that also. When the NK cells, now comes the very interesting 2 minutes of this presentation. When the NK cells enter inside the uterus, they get labeled as uterine NK cells, UNK. Understanding? From the peripheral cells, they become uterine natural killer cells. You will say, how is that possible? That is simply not going to happen. How can this become uterine natural killer cells now? It does. It does. Actually, it does, honestly. And that is because peripheral NK cells are acted upon by two great human beings. One is estrogen and second is progesterone. And as a result of this, ovary is very, very important. Okay. Ovary, through the cycle of HPO axis, allows estrogen and progesterone, both of them, to be produced cyclically in such a manner that the peripheral natural killer cells, which are circulating in the blood, when they enter the uterus and get deposited in the uterus through numerous mechanisms, they get converted into uterine natural killer cells under the effect of estrogen and under the effect of progesterone. Okay. So now here comes a very important point. What happens to women who don't have ovaries, postmenopausal women who try to become pregnant? First of all, we'll be using donor eggs. Then what will happen is the uterine natural killer cell ratio inside their uterus will go down drastically because estrogen is also absent and progesterone is also absent. Understanding? And that is why all of us follow this technique, which we all do. But now today we will realize the importance, which is called priming. What is priming? You give 3 months of estrogen and 3 months of progesterone to the patient before you do embryo transfer, isn't it? And that 3 months of estrogen and progesterone is to make sure that there is some amount of formation of uterine natural killer cells, so that when you actually put that embryo inside a postmenopausal uterus, okay, the natural killer cell is present and it allows for modulation. But despite our efforts of priming, we all know that in a postmenopausal uterus, the success rate of IVF is going to be less as compared to the success rate of a of a reproductive uterus, isn't it? Right? So this is the mechanism of action inside that. Now, okay, let me just delete some more things. So estrogen came, progesterone came, they converted these cells into uterine natural killer cells. Correct? Natural killer cells means it will go and kill. Okay. So what does the natural killer cells normally end up doing? It will go and destroy. But uterine natural killer cells will end up going and protecting. Okay. That is the only thing which you should remember. Of course, guys, remember, uterine natural killer cells can be easily studied by doing something called as a Pipel biopsy. Once you do a Pipel biopsy, uterine natural killer cells have strong immunoresponse for CD56. Peripheral natural killer cells have strong for CD16. Okay. And calculating the ratio. Now you will understand when you look at immunology reports, you have CD56 strong positive, you have CD56 weakly positive, and you have CD16, and you will be scratching your head. अरे यार क्या लिखा है ये report के अंदर? And then you have to at least smile in front of the patient, no? So in order to smile in front of the patient, even if we don't know anything, we'll smile. Okay. But in this situation today, mark these words that CD56 is a marker of uterine natural killer cells. And the proportion of CD56 in a uterus sample, that means in an endometrial sample, should be at least 10 to 30%. This is clinically important because that indicates optimal activity of uterine natural killer cells. Understanding? Fine. After you understood all this, has it become little bouncer? Shilpa madam, shall I stop? I will only take 5 minutes more, promise.
Yeah, finish in 5 minutes. Otherwise, nothing is understood.
Okay, sorry. You really did not understand all these things I spoke?
I did, because we had already done something like this. But for somebody who is attending for the first time, it may be a little overwhelming.
Okay, fine. So uterine natural killer cells, when they are present in the uterus, the embryo, as I told you, is a very smart person. Instead of presenting HLA-A and HLA-B, if it presents natural killer cells will go and kill it, it goes and opts to present HLA-C. Okay. So the trophoblast is going to present HLA-C to the natural killer cells. When the natural killer cells looks at HLA-C, remember, HLA-C is highly variable. Extreme variations occur in HLA-C. HLA-C and uterine natural killer cells are going to become very good friends with each other. So I will just draw that as a separate thing. Okay. HLA-C plus natural killer cells. They both love each other. Okay. They interact very nicely to each other, uterine natural killer cells. And they actually do this through something different, which is called as KIR receptors. Okay. They are basically killer receptors. Okay. Simple. Nothing. Don't think so much about it. Okay. Now you will understand the importance of the blood test, which is done in immunology, right? A lot of times we ask the patient to do KIR phenotype as well as HLA-C typing. Correct. This is a commonly available blood test, cost 9,000 rupees, which we ask the patient to do. And based on this, we take a call as to how badly the immune system of that patient is affected, isn't it? And if the ratio of HLA-C and KIR phenotype, especially phenotype A, is expressed, that means very high chance of abortion, isn't it? But when they act with each other very, very nicely, they cause something called as this. That is development of spiral arterioles, which allow trophoblast to grow in size. Okay. It allows for spiral arteriole formation, and simultaneously it allows for invasion, trophoblast invasion. Now remember, how important is this uterine natural killer cell? If these two guys do not form properly in life, spiral arteriole and trophoblastic invasion, then as we have studied in high risk obstetrics, it increases chances of preeclampsia, it increases chances of intrauterine growth retardation, it increases chances of low birth weight, it increases chances of abortions. As a result of this, your early gestational science is extremely important for the long-term fetal outcomes, isn't it? And that is why uterine natural killer cells is very, very, very important, right? Now, after having loaded you with so much information, which I already told you. Just I wanted to touch upon something which is very small, very similar, but I'm sure it is going to benefit you because we have studied this a lot and it has become a very irritating thing for all of us. Okay. So, in pregnancy, when all these things are happening simultaneously, so natural killer cell is not the only cell which is present inside. Along with the natural killer cell, okay, there is presence of something called as T cells. Okay, what are T cells? They are basically T lymphocytes. Okay, now T lymphocytes can be divided into many categories, but for the sake of information, two people whom we need to know very nicely is helper cell number 1, helper cell number 2. Bus, just remember that much. That is what we need to know and we need to understand very nice. Now, we have often been told that in pregnancy, ratio of TH1 is to TH2 is very important. How TH1 and TH2 is altered matters because TH1 and TH2 upregulation, downregulation, imbalance is going to give rise to formation. I mean, is going to give rise to abortions. So in very simple logic, without destroying your head, let me put it as a very simple terminology. TH1 is basically pro-inflammation. TH2 is basically anti-inflammation, correct? So ideally, in pregnancy, TH2 ratio should be more. But lots and lots of recent theories have started to challenge this. They have started to tell that TH1 by TH2 is ideally increased in the first trimester. It is then decreased in the second trimester and it is again increased in the third trimester. So the take home point is TH1 by TH2 ratio may or may not be something which is clinically important at this point in time. Okay. If all these people work together very nicely in association with uterine natural killer cells, the pregnancy from an embryo will get converted into a clinical pregnancy with a cardiac activity. Okay, this is the importance of this lecture. Once the cardiac activity becomes positive, understanding, the placentation itself becomes so strong that the activity of uterine natural killer cells, the activity of HLAC, the activity of TH1 by TH2, and all these other things which we try to state and which we try to speak is going to subsequently decrease. That is the reason why our entire game is basically dependent on getting cardiac activity. That is the reason why we are worried about implantation. And that is the reason why in early pregnancy losses, we always try to have a look if there was cardiac activity which was present or if it was not present. Okay, friends, this is so much compressed into 10 minutes. Okay, I think this was the best which I could compress into 10 minutes and try to speak with some stupid examples, of course. But then I think this is the best way to understand immunology, right? All the subsequent sessions which we take, this lecture will draw the basis to that. Because if you understand this much, very basic it is. Actually, it is very basic. Okay. So if you understand this much, then life is done. Okay. Shilpa madam, you can probably ask anything. No, Sanchari, there is no recap. Okay, you come to the hospital tomorrow, I'll teach you.
It was a little too much. Okay.
Yeah.
So,
but immunology is such. What to do?
No, that is true. See, the point is like you will have to finally tell people as to the whole
importance.
The whole importance.
Yeah.
Of
So I will cut it down in one line. Yeah. I mean, if anybody has to learn anything, I'll just cut immunology down in one line. Okay. Remember, uterine natural killer cells normal ratio in the uterus is important. That is between 10 to 30%. If the ratio is less than 10%, postmenopausal uterus, there is a problem. If the ratio is more than 30%, that is in cases of chronic endometritis, tuberculosis, Asherman syndrome, submucosal fibroid, polyp, endometrial hyperplasia, in all PCOS, in all this situation, that is also a problem because even that is going to interfere with early pregnancy implantation. That is why all of that can cause abortions. Understand? Simultaneously, along with this, please remember one very important thing. All these factors are extremely variable. That means I'll give you my example. See, I have two girl daughters. Okay. So what happens is both the children are born from my sperms only and my wife's eggs only. But both the times, the HLA matching which would have occurred, the sharing of the alleles which would have occurred, which would have presented the HLA-C would have been different. In Demira's situation, it would have been different. In Ruhi's situation, it would have been different. And that is the reason why you can't really say that if in the first pregnancy you had an abortion, in the second pregnancy also you will have an abortion. You can't tell that to a patient. Very important clinical point. Because HLA-C is extremely variable. How this HLA-C will go and present to that uterine natural killer cells, Bhagwan ko malum. We don't know.
Stop right there. This is not about that. I mean, you're going way ahead of what is supposed to happen. See, you're talking about all this, like when you're dealing with recurrent abortion patients, when you're dealing with recurrent implantation failure patients, when you're talking about postmenopausal, where the uterine natural killer cell is less than 10%, you can still do a donor and get her pregnant, right? And still you can get this thing. So, it is the relevance of all these tests, like which are taking too much of popularity at this moment, like doing mum1, doing CD 130,
is only for self-cycle IVF. Or it is only for self-cycle cases. If you want to do donor embryo, then it is so easy. Become a surrogate mother. It is any which way accepting embryos from outside. Nobody cares about HLA-C matching in that situation, because HLA-C is not going to match at all. Understanding? And still that pregnancy, I mean, still that uterus is accepting the pregnancy and it's carrying on that pregnancy till term. Understanding? So that is the importance of HLA-C's polymorphisms, as well as understanding that all these tests are only going to be beneficial if you are doing self-cycle. If you are doing the test and then asking the patient to do donor cycle, that means you should not have done the testing in the first place itself.
Yeah, true. So when you're doing the HLA typing, then it is extremely important to stick to the same oocyte and same.
This is only for self-cycle IVF. If you want to change IVF gametes, then this science is not for you.
Yeah. And also when you're talking about endometritis, when you're talking about even like Asherman's or PCO or anything, see, any of these diseases, like how we discussed in the beginning, like either drugs, either infections, either any of the factors can really, like, change the immunology of the endometrium or the milieu. And we have to work on finding out the reason. And most important in Indian population is the infection. That 100%. Is the chronic endometritis. Rather than looking for HLA matching, rather than looking for ABC and their alleles and 50%, 30%, whatever it is. So we should think of the simpler things.
Correct.
And what is your opinion on using steroids? Forget about all this. See, previously when these things were not available in every city, the commonest thing that everybody used to do was just use Visalone or...
Absolutely. See, people, in fact, in so many IVF clinics, if you see, people still give low-dose steroids as a routine part of their embryo transfer protocol, because they think that they may or may not have evaluated for immunology and there is no harm in giving that low-dose steroids, right? But when we take our lecture on low-dose steroids, we will have the beautiful conclusion as to why you should not use low-dose steroids in all these patients without any indication. If there is an indication, continue to use it. If there is no indication, then it is going to be detrimental and it is not going to be good. And as a result of this, if it is used as an empirical therapy, it's not correct.
So what do you think about these routine DNCs that people used to do in the past? Is this injury which is caused to the endometrium, is it going to help in improving the implantation by improving the immunological factor?
Simple, no, madam. See, if there is uterine injury which is occurring, it will recruit stem cells. If it recruits stem cells, it will recruit uterine natural killer cells. If uterine natural killer cells are recruited, automatically probably the proportion of uterine natural killer cells would go up. And if it goes up, it may allow for pregnancies, because I know of so many seniors who will tell us that I did a DNC and she conceived after 3 months.
Yeah.
And that used to be pretty common as a DNC used to be a treatment for infertility probably once upon a time.
Yes,
understanding.
Yes.
And now it is no longer a treatment at all.
So do you think this is the basis of doing endometrial scratch probably on
but it is outdated, madam. Now that endometrial scratch is outdated, because see, endometrial scratch is performed by God every month. If you have a routine menstrual cycle, your shedding goes up till the basal endometrium any which ways, madam. And that is nature's mechanism of doing an endometrial scratch. In fact, that is the reason why, despite all parameters being same, a couple will probably conceive in 1 cycle and have an abortion. And after 3 cycles, you allow them to wait so that 3 cycles of shedding has occurred, and then when they conceive, they will have a successful pregnancy, right?
Mm-hmm.
So probably the UNK cells would have got altered in that.
See, I one suggestion is like, I think you should, this is okay as a basic class. So you should just like, make it a little more simpler and a little more, I think, understandable for.
Yeah. Our next classes will cover pathologies. No, this class was only on understanding immunology, because we probably need to understand all these things. Until we don't understand these things, it is not going to benefit either one of us.
Yeah, sure. Okay. Thank you so much. It was really wonderful to know these terminologies, at least. Forget about the whole lecture, but it was good. Thanks. I think many people will benefit from it.
Thanks.